This session is chaired by Dr. Ahmed Bayoumi, a professor at the University of Toronto's Department of Medicine and Institute of Health Policy, Management and Evaluation. Welcome, Dr. Bayoumi.
Thank you, Natasha. Sorry about that. And thank you to our panelists. And so far, it's been, I think, a fantastic start to the day. And I'm very much looking forward to this panel. We have, I'm just going to say a few introductory remarks, and then I'll turn it over to our panelists. We're actually going to have 4 panelists today, and I'll introduce them as they speak. But so the title of this panel is Engaging People with Lived Experience Best Practices. I'm going to talk a little bit actually about some of those terms in a bit, but I want to start by making 4 observations. First, as we've already been discussing today, substance use itself is highly stigmatized, and there is discrimination against people who use drugs within healthcare systems, as well as other systems and within society at large. What that's taken, I think, as a given by everybody who works in this space. What I think is not always appreciated is how our research has the potential to add to that discrimination and the potential to do harm. And it is incumbent, I think, upon everyone who works in this area to consider whether their work is contributing to harm or decreasing harm. Second observation is, and this is entirely anecdotal and non-evidence-based, but in my experience, very few modelers work closely with people who use drugs. And many modelers have probably not spoken directly to people who use drugs in the context of their work or even outside of the context of their work. Third observation is that calls for community engagement or public engagement or patient engagement or those sorts of terminology has become increasingly popular across all sorts of health services research and health research in general, but much less frequently do we stop and actually ask why we want to have that level of involvement or that kind of involvement. It's often taken as a given that it's good. It's less often taken, it's less often considered about why we actually want that and how it's going to change the way we do research. And then the fourth observation is that if we think about the innovations in drug policy, particularly around the opioid overdose crisis, those innovations have come almost exclusively from the community. They don't actually come from researchers. They don't come from clinicians or practitioners. They don't come from policymakers. So initiatives like supervised injection, like naloxone distribution, like safer supply of opioids, even decriminalization are initiatives that have come from the community. It's therefore incumbent, I think, upon researchers who want to do research that has a policy impact to listen to people in the community and to do so in a way that is meaningful. So as I said, today's session is called Engaging People with Lived Experience. I'm hoping over the course of this session, we've already had some of this discussion. We also can talk a little bit about terminology because words are important. And when we talk about stigma and discrimination, we have the words themselves carry meaning. We've already had some discussion in the chat in the last session about the use of the term peer. But even terms like people with lived experience, people who use drugs, people who inject drugs are important to think about what we mean by those and what words are the best words to use. But I also want us to think about words like engagement and consultation and participation and partnership and co-creation. And they're often used synonymously, but they're not actually synonyms. And they have different levels of they signify different levels of involvement of people who use drugs in research projects and really different levels of ownership and different levels of accountability. So I encourage us also to think about those. And then even when we're talking about the involvement of people who use drugs in our research, we sometimes talk about them as advisors or as consultants. Sometimes we talk about them as researchers, sometimes as research assistants. But again, those are not synonymous, and they also signify different levels of involvement. So, hopefully thinking about the words can give us some avenue into thinking about some of the bigger questions as well. I do want to say my research career has been characterized by increasingly working with people who use drugs more directly. I think every year that I've been an independent researcher, and it's been incredibly important to me. It's been fruitful to me. I've made many mistakes along the way, and I've learned a lot. None of those mistakes have actually deterred me from going further and learning more. So I think one of the other things that I have observed is that people often have some trepidation about trying to work with people in the community. But in my experience, it's been nothing but positive in terms of helping me to recognize how to do things better. And it's changed the way that I do research. But so I do want, so that's all in the way of some introductory comments. I want to frame today's session around sort of 3 key questions. And we've asked each of the panelists to think about these questions and to just pick those particular aspects of the questions that they think are most salient for what we are discussing today. The first is really to understand why working with people with lived experience is important for drug-related research. Back to that question of not just did we do this, but why do we actually want to do it? The second question is to describe how to work with people with lived experience in a way that is meaningful, right? So how do we move beyond tokenism, beyond checking off boxes that we have done this consultation, to a way that actually makes the research meaningful and makes the application of the research meaningful. And in particular, what should we not do in that sense? And then the third question is to think about how working with people with lived experience will change the way that we actually do our work. In real practical terms, how should it change, and how could it change the kinds of work that modelers do? So I'm going to introduce our first panelist. So our first panelist is Zoe Dodd. Zoe is a good friend of mine and a colleague. Zoe is a long-time drug user advocate, a harm reduction worker, an organizer, and a scholar. She is the inaugural community scholar at the MAP Center for Urban Health Solutions and a co-organizer with the Toronto Overdose Prevention Society. And for the last 2 decades, her work has focused primarily on issues related to hepatitis C, HIV drug policy, poverty, and overdose. She's co-founder of the Toronto Community Hep C program, which is a program for people who use substances to access treatment, care, and support in a community-based setting. She's been instrumental in addressing the overdose crisis, known for helping to establish an unsanctioned overdose prevention site in Moss Park, which ran illegally for a year before receiving funds and moving inside. She's the recipient of several awards, and she's published many works and engaged with several research projects. She has a master's degree where her work focused on people's experience with mandated drug treatment. And just in the interest of transparency, one of Zoe's co-mentors in her role as community scholar. But I'll turn it over to Zoe for her comments.
Thank you. Thanks. Yes. Ahmed is one of my mentors. So this is like a new position at MAP Center for Urban Health Solutions. And I think me and Ahmed were in discussions for a couple of years about how there was a need to have a role where people who use drugs or people with lived experience or people who are engaged in research could actually like develop and create their own research projects and work with their own community. And it's actually really exciting to be the first there, because I have been involved in a lot of academic work since I started in harm reduction, even with just the high school diploma. And you know, that opportunity to engage in research, to contribute, to make intellectual contributions to the work, and also as someone who's like grounded in the work and basically doing ethnography every single day, I have a lot more, and I think this is the case for a lot of people who are involved in harm reduction or who use drugs or attached to the culture around using drugs. We have a lot of knowledge that oftentimes researchers don't have, because actually I've rarely ever met researchers, unless they were doing their own work, who've actually said they even have tried drugs. And we already aren't at a level playing field, because I think, not to be rude, I think a lot of researchers are quite square and will drink, but they're not the same things that lots of people I know are doing. So, but it means that like where we come from, our positionality is so different. I just want to acknowledge that I'm speaking to you from the Dish with One Spoon territory. So this is the home of the Anishinaabe, the Mississaugas, and the Haudenosaunee. And the Dish with One Spoon Treaty was a territory to protect the land. And when European settlers came here, they were invited to be a part of that treaty. It was a treaty of peace and about friendship and respect for where we were. And the dish was passed around, and people were allowed to take what they need. And the problem is that we live in a society that doesn't take what they need. They just take, especially when settlers came here to Canada, and we live in a colonial state, which is the same as the United States. And the reason why this is also important, because this is intersectional to the work that we're doing. The people who are being the most affected by the overdose crisis, Indigenous people have been disproportionately affected. And when we're thinking about modeling or we're thinking about research, we have to think about the communities with which we work with. And it's not just homogenous groups. We also have to think about how people have been affected by certain policies, about how our countries are designed, about theft of land, all of those things have affected people's lives. And so I personally think about my commitment to trying to live peacefully and responsibility in the treaty with which I live in, with the Dish with One Spoon Treaty, and what my commitments are to that. And I think one of the problems with research, when we have to have a discussion about working with people with lived experience, is that and especially when we're doing research around drug use, is that the fact that people have no relationship to the people on the ground or the people who use drugs shows that there's a level of extraction, that there is an idea of who knows best. And I think that is the crux of the problem, is that we could be working more collaboratively and working more respectively. We could be working in that building of trusting relationships and reciprocity if we actually saw research not as an extraction of knowledge or that we know best, but that as a collaborative process. And I think modeling could have that, but oftentimes I've met modelers who have had no experience with talking to a person who uses drugs, blows my mind, but has ideas that then, when talking through them, have massive limitations if they're not actually connected to what's happening on the ground. And I really appreciate Ahmed's comments about how things came about. Supervised injection site did not come about because there was some sort of public health logic and this was a great intervention. That is not what happened. Naloxone did not come about because, again, public health was like, yes, we need to intervene. Let's make this successful. No, Dan Big in the United States at the Chicago Recovery Alliance was like, naloxone is an intervention that can save people's lives. Let's get it out to people who use drugs and let's break laws for people's survival. That's what people are doing all the time. And so, what is the role then of people who extract knowledge or people who are working on issues related to substance use? What is then your responsibility? So in the context of the overdose crisis, or in the context of COVID, actually, research stopped. That was not related to COVID at the beginning. Everything ground to a halt so that we could focus on COVID. And I personally, in the first few days of everything shutting down, sat at my desk and cried because I was still working out in the field as a frontline worker. And I thought, shit, everyone around us is going to die. I did not think that I would lose coworkers. I did not think that I would see dead people on the street or watch a dead person come out of a porta potty. I did not think that when I left my office, I would find people overdosing on the street and having to respond. I did not think that was, I didn't believe, it was like a horror movie when everything shut down, but everyone was focused on COVID and we watched the communities we work with just die. They died and they have been dying. you know? And so for me, when we think about working with people who use drugs, we also have to take in consideration at this time during COVID and that we've lost a lot of people. It's not trauma. We've been socially abandoned by government. We have been abandoned by people who also work with us to make sure that people are at the tables, to make sure they're included. And we've watched research sort of carry on in particular ways that don't include people who use drugs. They don't include them at the beginning. They don't include them in the design. They're not including them in the analysis, and they're not including them at the end. They're not including them in publications. They're not including them in outputs or knowledge translation. And we fought so hard to have more inclusion of people, and people have created groups, like organizations, like the Canadian Association of People Who Use Drugs exists, so that as a national organization, people could work with them in collaboration, or at VANDU in Vancouver, or the Toronto Drug Users Union. Like, people set up their organizations so that they could work collaboratively and not, because people who use drugs are not like a homogenous group either. So sometimes it's easy just to tick a box and find a person, but having a connection to an organization is substantially much better. But during this time, those kinds of connections, because of the limits, because of using like technology, they've limited those kinds of interactions. But what I've seen more is people just thinking that they know best. And I think our work is much richer when it is a much more collaborative process, and that people are thinking about, okay, maybe that is the limitation in this, that would be the limitation in this, didn't consider this, because actually on the ground, that kind of evidence, you know, I've witnessed hundreds of overdoses. I could tell you what an overdose looks like with benzodiazepines and fentanyl. I could tell you how to respond to that because I've witnessed it and had to deal with that. We do drug checking. Has that changed how clinical practices happen? That we've had benzodiazepines in the dope for 2 years, and that we have drug checking that shows that, and medical practitioners have access to that? It has not changed their practice. They're not doing mass benzo tapers with people. So I think for me, it's just about really taking a step back and thinking about how the richness of our work could be, and how much we could be supplementing or listening to the people on the ground who are saying, this is actually what we need. We don't need you to do this project. We need you to help us so that people don't die. And this is what we see as what we need help with. This is the evidence we need to gather, because we're shown data sets all the time. This is how many people died. Oh, more people died last month than they did the month before. Oh, there were more overdoses the month before than the month. So what? At this point, so okay, so we know, like, everybody's dying. So what are we going to do about it? And that for us has been the tragedy of all of it, is that there hasn't been an urgency, there hasn't been an emergency, there hasn't been a sense of urgency from people who are often considered our allies. And I'm talking about allies in harm reduction too, like, just, it's all of it. We'll just wait, because for me, like, what I've seen is a drive to publish, a drive to get into journals. I've seen more of a drive to be acknowledged by academic peers than to be acknowledged by the community, and to be reflective that your research is actually helping the communities you seek to help. So that's what I want to say about that, because we have like a whole panel of other people to talk, and I don't need to go on. So thank you, Ahmed.
Thank you, Zoe. That was great. And, you know, I have to say, I'm on paper, I'm Zoe's mentor, but I learned more from her than she does from me, I think. Our next speaker is Rubén Diazconti. Rubén is the coordinator of the harm reduction program at Clínica Condesa, which is the main HIV clinic in Mexico City. He's trained as an anthropologist, and he's collaborated on a range of research projects, has experience working with people who use drugs across Mexico, including at the Mexico-US border. He is an active advocate for the decriminalization, destigmatization, and demystification of drug use in Mexico. So Rubén will be speaking in English and Spanish, and we do have Carmen Cortright with us today as well, who will provide us with translation services. She's from Lighthouse Translations and Interpretation. She'll be providing the Spanish to English translation. And Rubén, over to you.
Thank you, Ahmed. Una disculpa, I apologize for doing this in Spanish. My English is so bad, but maybe I can try to speak a few in English, but I feel more comfortable speaking in Spanish because I am more fluid in the talk. Carmen, gracias por traducir. Bueno, I am a social anthropologist. I was educated to make ethnography under the methods and the techniques of the anthropology, like the participant observation, the rapport, the horizontality in the relationships with the others. In my formation, in my profession, I learned that the reflexivity, it refers to the conscience of the investigator in the relationship with the field. One of the history, the Clifford Geertz, an anthropologist, narrates in his book, La interpretación de las culturas, the interpretation of the cultures, is about the pelea de gallos in Bali. I don't know how to say pelea de gallos. The fight.
We're going to say cockfights in Bali.
Yeah, in Bali. When Geertz, blondie man, tall, in Bali, he decides to visit the neighborhoods where that fight se llevaban a cabo.
Where the fights were were happening.
De forma clandestina, pues estaban prohibidas.
They were prohibited, so it was a clandestine situation that they had with the cockfights.
Clifford Geertz adopts the modus vivendi in that moment of the Balineses. La policía llega porque prohíben esas peleas.
The police gets there because these fights are illegal.
En vez de pensar que él no sería sujeto de sanciones por ser un investigador extranjero,
instead of thinking that he would not be part of the people that were going to be penalized because he was a researcher from abroad, he
decide correr con la multitud huyendo de los guardianes de la ley, de los policías.
He decides to run with the crowd as if he were part of them and get away from the police.
De esta manera, la gente se gana la confianza, él se gana la confianza de la gente y la gente de esta manera se abre con él para contarle sus historias, invitándolo a convivir como si fuera un miembro más de la comunidad.
Because he ran with the crowd, he gained their trust and they started to open up to him because they saw him as a part of the community.
Esa fue una de las enseñanzas que a mí me impactó cuando escuché sobre eso en mi carrera como antropólogo cuando era estudiante.
That was one of the lessons that was most important to me, something that I learned while I heard the story as a student.
Quiero mencionar que antes de ser estudiante de antropología, yo conocí la heroína en 1996. Soy usuario de heroína esporádico, intermitente desde ese tiempo. Y también paciente de clínica de metadona.
I use heroin since the 1990s, 1996, sporadic user, and I've also been in the methadone clinics.
Entonces, conjuntando mi saber como antropólogo y mis conocimientos como usuario de heroína fue que yo me involucré en proyectos, en investigaciones sobre el tema de uso de drogas inyectadas en el norte del país.
So the way I joined this discussion is because I have that joint experience as an anthropologist, but also as a heroin user. And that's how I became part of the study of what's happening in the north of the country.
En mi acción como investigador, correr con la multitud consistió en visitar los sitios de venta de heroína, consumir incluso con los mismos usuarios y de esta manera ganar la confianza de ellos para comprender sus dinámicas y sus patrones de consumo.
Mr. Diazconti's version of running with a crowd included, as a researcher, going to the sale areas where they were selling the drugs, consuming with other users, and learning what was happening in the areas from that perspective.
Razones para justificar mi consumo de heroína, podría decir al menos dos. Incomodidad con mi identidad en esos momentos de apertura hacia las drogas cuando era joven. Es una.
One of the reasons I can justify my use of heroin is that I was dealing with my identity and feeling comfortable with my identity at that point. That would be one.
Y la falta de seguridad ante la incertidumbre.
And feeling unsafe in front of so many moving parts that didn't necessarily make sense.
Sin embargo, siendo antropólogo y usuario de heroína, no se me dificultó acceder a esos proyectos de investigación, primeramente en el Colegio de Sonora.
I first joined these studies as an anthropologist and heroin user. Easily, there was no problem in me joining in, especially at the start in Colegio de Sonora.
Y posteriormente en el Centro Nacional para la Prevención y Control del VIH-Sida en México.
And afterwards in the Center for Control of AIDS and HIV in Mexico.
También he participado con la Universidad de California en el proyecto El Cohete en Tijuana.
I've also been part with the University of California with a project called El Cohete in Tijuana.
Y con el Instituto Nacional de Psiquiatría. Aquí en México.
And with the National Psychiatry Institute.
Mi participación posicionó el tema del uso de drogas inyectadas y VIH en Sonora. Fue el primer estudio académico que salió a la luz en 2008 en esa entidad.
My study was the first to come out in Sonora about the issue of drug use in the area. And it was published in 2008.
Derivando en la formación de un colectivo conformado por personas que se inyectaban heroína en Hermosillo, Sonora, llamado AXRED, Acción para la Reducción de Daños.
So this was part of a collective of people that were using injectable drugs. And it was called ASREC, which is like a commission to deal with the risks of drug use.
Existe evidencia en YouTube de ese proyecto. Hay un video llamado Cazando Cohetes. Cohete se le llama a la jeringa.
So we have some evidence of that project on YouTube, and it's called Cazando Cohetes. Cohetes means in English, the syringe. So it's hunting syringes.
Yes. Considero que la participación de pares en la investigación proporciona veracidad y efectividad en las estrategias que se pueden proponer.
I believe that including the people in the community, in this particular community, in the studies will help us be better at coming up with strategies to dealing with any kind of situation that comes from this.
En México hay muchas organizaciones civiles, pero pocas toman en cuenta el trabajo de pares.
In Mexico, we have a lot of civilian organizations, but they don't really use that much the work based on the participation of users and our colleagues, let's call it, in this field.
Involucrar a personas con experiencia vivida en el uso de drogas en la toma de decisiones garantiza que los servicios de reducción de daños reflejen la necesidad real y sean equitativos.
When we have people that are part of the community of people that are using drugs, we are going to be better in the decision making when we try to come up with initiatives to deal with the different situations that come up out of this one central topic.
La participación de pares favorece la programación de políticas adecuadas que atiendan las necesidades reales. la confianza, la corrección de los desequilibrios de poder entre investigador e investigado deben de ser temas transversales cuando se habla de la importancia de incluir pares en los proyectos de investigación.
When we use part of the community of users and we involve them in this type of initiative, we make sure that the inequities between researcher and researched is dealt with in a more equitable manner. It's very important that they have a voice in whatever decisions or initiatives come out of our efforts.
La participación de pares aumenta la equidad de los servicios de reducción de daños, facilita la comunicación, genera confianza, reduce el estigma y la discriminación para eliminar de esta forma las barreras sociales.
When the community is involved in these initiatives, we have a better communication, we have more trust. We reduce the stigma around these situations and the prejudice that comes socially with the topic.
Gracias a que hemos hecho uso de personas que tienen conocimientos sobre el uso de drogas inyectadas, es decir, pares, en los proyectos en los que he participado, hemos podido alcanzar las metas propuestas y visitar los sitios más recónditos en las ciudades donde hemos trabajado.
Thanks to the fact that we have used people in the community, people who are using injectable drugs as part of this, and they have this life experience, we have been able to reach our goals, and we have been able to go to the most lost parts of the country, those places where otherwise we would not be able to go.
Al final, los pares son los expertos y los conocedores.
In the end, the users are the experts. They have the life experience and knowledge.
Lo que debe evitarse es el sesgo, anteponer la opinión propia ante la de los demás.
We have to be very careful not to use our prejudice when we are doing this type of work. We don't want to have our opinion or our prejudice influence what other people are telling us and what their life experience is.
Al final, el actuar como parte de la comunidad debe ser solo una estrategia para alcanzar los propósitos de acceder al terreno, al campo, y observar de primera mano las dinámicas.
So being part of the community is important, and its main goal, its main purpose is to be part of the field and be able to observe firsthand what is going on in this community, in this area of study.
Como investigador par, se debe evitar formular preguntas basadas en la experiencia propia. Hay que tomar en cuenta el contexto y las necesidades de los otros.
So it's very important as you're a researcher and you're also part of the community during this research effort that you don't ask questions based on your own experience. You have to be open to listening to the life experiences of other people around you.
Muchos esfuerzos de participación de pares se limitan al intercambio de información sin compartir ninguna autoridad para la toma de decisiones. Y ese es un vicio que tenemos que atacar.
One of the problems of many of these studies is that we're using them just to exchange information, and we're not really allowing the community to be part of that analysis and part of that decision making. We're just using them for their information. And that's something that we have to stop doing.
No hay más experto que el propio usuario. En México les llamamos a los que se inyectan heroína tecatos.
In Mexico, we call people that use injectable drugs tecato. In many other parts of Latin America also. But we have to be very careful that we include them in this experience. We know about their life experiences and we take it serious.
En antropología llamamos saberes legos a aquellos conocimientos propios de los nativos.
They are the experts, and in anthropology, we call this have the life experience or understand the life experience of the natives, quote unquote.
La producción del conocimiento experto deriva de estos saberes. Por ejemplo, nos dimos cuenta que a falta de naloxona, la sal fue un recurso que evita la muerte por sobredosis.
So they have this expert knowledge, and in doing this research, we found out that if we don't have Loxona, we can use salt to deal with the situation so that a death is averted.
Esta es una estrategia que se usó mucho tiempo en varias partes de México donde se usa heroína. Hemos
This was a
aprendido,
strategy that was used very often in many parts of Mexico where heroin use is prevalent. We have learned
hemos aprendido que las jeringas más aceptadas por la población de Ciudad Juárez, por ejemplo, son las de .40 milímetros por 16 milímetros.
So we have learned that in Ciudad Juárez, some of the syringes that people prefer are those that are 0.40 ml by 0.16 ml.
Sí, es una jeringa, es una aguja más gruesa que puede atravesar partes duras del cuello.
So it's a very thick syringe that can go in easier on areas such as the neck.
Agujas normales de jeringas normales no resisten cuando se inyectan en lo que se llama el vaso en Ciudad Juárez, que es aquí esta parte del cuello.
So the normal syringes that you would find elsewhere are not strong enough to be able to be used in the area our speaker just showed you on the screen, which in Mexico is called el vaso, and it's part of the neck.
Sin que los usuarios reales de heroína nos hubieran dicho esta información, jamás hubiéramos entendido qué jeringas son las que son mejor aceptadas.
So if the users in the area had not been able to tell us or share their experiences with the different syringes, we would have never known which syringes are the ones that are preferred by the community and why.
En Hermosillo, en 2002, el gobierno compró jeringas a las cuales se les podía quitar la aguja. Esas jeringas son llamadas rateras. Nadie acepta esas jeringas. Esas jeringas caducaron en las bodegas. Nunca salieron a las calles.
So to give you an example of how public policy can be influenced by this, in 2002, the area of Hermosillo bought certain syringes where you could take the needle out. And that was just left in the stores because people don't want them. They don't use that. So they expired in the stores and were good for no one.
Y fue un gasto, un desperdicio de dinero, porque se
It was
compraron muchas.
They bought a lot of these syringes that were never used because people didn't like them. And that meant that was an expenditure that was just lost, a lot of money lost.
Entonces, es importante la participación de personas con experiencias vividas o pares.
So we really need people that are living, that have the living experience, the life experience of being a user to participate in our research and in the initiatives that come out of it.
Porque así hay garantía de que las intervenciones serán bien recibidas y aceptadas por la comunidad.
That guarantees that the community will accept the initiatives that come out of these research projects. It's part of them.
Así como la interpretación de la información muchas veces puede ser mal interpretada cuando no se tienen las herramientas o el conocimiento necesario propio del contexto que se investiga.
If we don't understand the context of what we're researching, if we don't have the that context, probably our interpretation of the facts or the information will be wrong. So we really need these people in order to make sense of the information appropriately.
Entonces, personas con experiencias vividas son todas aquellas personas que tienen conocimiento sobre el terreno, sobre el campo, sobre el contexto y las dinámicas propias del campo de estudio.
So the people that we're mentioning as pares are the people that have life experiences that can teach us about the context, that have the knowledge of the situation, and that can give us that very important perspective.
Por lo tanto, todo usuario de drogas ilícitas es un par, y un par es una persona con experiencia vivida.
So that means that every user of illicit drugs is part of this community that we call a community of life experiences, and they are all can be part of our research.
Las intervenciones de pares incluyen la asistencia en la investigación, la consultoría, la promoción de la salud.
I'm sorry, I lost audio.
Okay. Las intervenciones de los pares incluyen la asistencia en la investigación, la consultoría, la promoción de la salud.
So that means that these people can be, for our research, they can be assistants, they can offer consulting services, and they can help us promote health issues.
Entre otras actividades como el apoyo de pares, la consejería, la gobernanza de los programas de reducción de daños.
And they can also help us in whatever program we establish by providing support, by providing advice, by being part of the governing body of these initiatives.
Hay una pregunta que hacen en esta mesa, que es ¿cómo pueden los investigadores acercarse a las personas con experiencias vividas para formar una colaboración?
There's a question that we have on the table right now, and it's how can a researcher get to this community, get to these people that have the life experiences in order to establish a coalition where we can collaborate?
Y esto puede ser a través del uso de incentivos en especie, pueden ser becas para metadona o dinero, siempre son una herramienta de garantía para acceder al contexto que se estudia mediante la intervención de pares.
So in order to get near these people that are going to be so helpful to our research, we can use different types of incentives. It can be money, it can be grants, it can be methadone. There are different ways that we can incentivize their participation in our research.
Como consejero también pueden trabajar como proveedores de kits de reducción de daños, como encuestadores, como exploradores del terreno.
They can explore the field, they can serve as advisors, they can provide health risk kits. So there are many ways in which they can join us in these efforts.
Okay. Puedo detenerme aquí para dar continuidad a la mesa y más adelante si hay preguntas, continúo hablando.
So
Gracias.
I will stop here. I thank you very much for your attention. If there are any questions later on, I will be here to answer them. Muchas gracias, Rubén.
No,
Excelente.
Gracias.
Thank you very much, Rubén, and particularly important points about being aware of how to work with people in the community and particularly listening to people in the community. Our next speaker is Dr. David Frank. David is a medical sociologist whose research examines opioid use, opioid-involved overdose, and medication-assisted treatment programs like methadone. He focuses specifically on the role of structural factors like criminalization and the war on drugs and the harms that people who use illicit drugs experience. David recently completed 2 pilot studies as a postdoctoral research fellow at NYU's Behavioral Science Training and Drug Abuse Program. The first examines how well pharmacotherapy programs align with the needs and goals of patients and patients' use and retention rates. And the second examines the willingness and ability of treatment providers to provide appropriate services for people on pharmacotherapy. David.
Thank you very much for that nice introduction. I'm going to share my screen because I have a little PowerPoint presentation. I hope I don't mess something up here. I often do. Okay, there we go. Okay, now if I hit slide start from the beginning. Okay, can you all see that? Okay, good. Okay, thank you very much. My name is David Frank, and I am, as said, a medical sociologist. I study opioid use and particularly methadone maintenance treatment, also buprenorphine, but particularly methadone maintenance treatment. And perhaps more importantly, I am a person who uses drugs, not in recovery, a person who uses drugs and who has been on methadone maintenance treatment for more than 15 years. I should point out, I am a qualitative researcher. I do mostly interviews and ethnography. I couldn't model my way out of a paper bag, but I'm hoping that my sort of dual lived experience, similar to what Rubén was talking about, can give you something to glean about the importance of including people with lived experience in research. So my talk today is called Reframing Methadone Maintenance Treatment from a Patient's Perspective, the Importance of Lived Experience in Research. Okay, so is that the right? Yeah. Okay, so I'm going to talk about some of the reasons that it's important to include people who use drugs in really all phases of the research process, in part by using my own experience as someone who both studies methadone and who is on methadone. And I want to point out there are lots of reasons to include people who use drugs in research. There's ethical reasons, there's quality of data reasons, there's credibility reasons. I'm specifically going to focus on one in particular, and it's kind of, again, similar to what Rubén was talking about with context, and that's how these issues are framed. I think we all sort of know as researchers that it's not just about answering these sort of abstract empirical questions that aren't linked to context. We all start any of our research processes with a set of assumptions about whatever it is that we're going to study, the object of our study. And these assumptions that we have, they guide all of our methodological choices, from who we're going to talk to what kind of questions we're going to ask, to the way that we're going to interpret the data that we collect. Just to throw out a really sort of blunt example, if you have sort of a normative perspective about laws, if you think laws represent some sort of social good or universal value, that's going to really affect the way that you study crime or crime statistics or people who commit crimes. Similarly, or conversely, if you have a more critical perspective, if you see laws as social control or a way of maintaining capital or racial and class structures, that will also affect the way that you interpret data. So I want to make a brief sort of criticism of the scientific method. You know, I like the scientific method as much as anyone, but I think, you know, when you apply it to socio-behavioral research, there are problems. This idea of the neutral researcher, this idea that knowledge is objective and that it exists somewhere out there. You know, I get it if you're studying molecules or space, asteroids, you know, but when you're studying these complex socio-behavioral practices and outcomes that are involved with drug use, it just doesn't work. I mean, I think it's kind of obvious, and science sometimes gets in our way of like the nose on our face. Like, of course, people who use drugs know more about drugs than people who haven't used them. Like, it's crazy that we would ever think anything of that, or that we would base our sort of institutions on this idea that research is somehow neutral. So yeah, that's my little. I'm not going to get on my soapbox about that, but I did want to get it in there. So to illustrate how these interpretive frameworks play out in our research and why we need people who use drugs to shake up our assumptions, I'm going to talk about some of my own research on methadone. And as I mentioned, I've been on methadone more than 15 years. So shortly after getting on the program, I started reading the scholarly literature on it. I wasn't in grad school at the time. I was just a person on methadone. And I just didn't like it. I got this feeling like, God, none of these people have a clue about people on methadone maintenance or why they use it or why they benefit from it. You know, there was this distance between the researcher and the object of study. And it was just obvious. And it infected the conclusions that they would draw, the implications, the policy recommendations. It was just clear, you know, that you guys aren't on methadone maintenance and you don't really get it. So, you know, I knew I could write about this as a person on methadone and, you know, make my critique. But I also knew that wouldn't be taken seriously, which could be a whole other sort of presentation on epistemology and expertise amongst marginalized populations. But I knew I wouldn't be taken seriously. They'd just be like, oh, you know, this dope fiend wants more methadone or whatever. So I literally went to grad school with the specific intent of challenging these narratives from the perspective of someone with lived experience. I didn't realize, actually, once I got into school, this could be a whole other talk too, that all of my mentors, well, not all, most of my mentors would be like, you got to bury that. You can't talk about your lived experience. Get back in the closet. And that wasn't going to happen. You know, the whole reason I went to school, you know, it was based on my lived experience, not on my desire to be a scholar. So, so yeah, it was the whole reason I went to school was to challenge some of these ideas. And to be specific about what it is that was pissing me off about the research, it was always conceptualized through this narrative of addiction treatment. Methadone, I'm talking about specifically. It was always seen, oh, well, methadone's an addiction treatment, of course. Addicts use methadone to recover from addiction. And because this was the conceptual framework that everybody used, the concepts that they employed to understand methadone or to you know, rate it, to evaluate it, were things like addiction, recovery, relapse, abstinence. You know, these were the concepts, the relevant concepts. And I'm not going to deconstruct them all, but I will briefly deconstruct relapse because that one drove me crazy. Like, I was always like, you know, I take opioids every single day on the methadone program. If I go and get them from another source, that's a relapse. Like, it just didn't, you know, it was like trying to put a square piece into a circle peg. It just, these weren't the right concepts for understanding methadone. Another problem with it was these narratives, this addiction recovery narrative, always positioned patients' difficulties with methadone on the individual level. You know, oh, this must be something about them as addicts or their disease or their addiction, and why are they non-compliant, and how can we make them compliant? It was really difficult for researchers to sort of come out of the box of this individual sort of frame of reference and look at larger structural contexts like drug policy and how that might play into people's experience on methadone. So, not surprisingly, my own lived experience on methadone was very different than what I was reading in the research papers. I didn't get on methadone maintenance because I was like, oh, you know, I'm an addict and I need to recover from addiction. It was, you know, it was actually the opposite. I was like, God, it's so hard to get opioids on a regular basis as a criminalized drug user when they're illegal. And it was really like, hey, you know, this will give me better access to a regulated kind of safe supply, sort of safe supply of opioids, which beats out, you know, having to hustle every day and having to commit crimes and having to lie and having to, you know, having no time to do anything but score dope. It was about that. It was literally about treating criminalization rather than treating my addiction. And this was similar to what I saw amongst the other people around me. Yeah, they used it as a tool to survive as a criminalized drug user. And there's my research on the next. Yeah, oh, I added a slide. I confused myself. Bear with me. Okay, so yeah, so my own research. I've done a lot of research projects. This is kind of just an amalgamation of all of them from my dissertation into the pilot studies that were mentioned in the introduction. All of my research is informed primarily by my own lived experience and of the lived experience of the people around me. You know, that's my source of information. My primary. I don't want to totally discount research. I learned a lot in my programs, and yes, you know, it was helpful. Of course, my sociology degree was helpful. But you know, the preference always is going to go to the lived experience. I know more about methadone from being on methadone than from reading about it or collecting data, whatever. This, of course, influenced my choices. I do interviews and ethnographic work, and I always conduct them as an out-of-the-closet person on methadone maintenance treatment. I never, you know, I did start, and I was telling the story the other day. When I first did my dissertation, I tried because that was my training, to be the neutral researcher, to not disclose my status as someone on methadone. And I was just like, this isn't working. I want to have a real conversation with someone about the real deal. And I experimented with disclosing my own status as someone on methadone. And that's when, the walls fell down. And of course, this is not how you're supposed to do research, right? You're supposed to ask the same questions over and over with the same expression on your face. And it's not supposed to matter whether it's me or my research assistant. But I threw all that out the window. I was like, I just got to, talk to people for real and find out what's going on. And because it was clear I was getting sort of some BS answers. And I'll refer to some of the reasons for that later on. Hold on one quick second. So yeah, my interviews themselves were unstructured and ethnographic. At least they became that way. They became more like conversations, not very scientific, granted, but I bet it against, your most methodologically rigorous survey any day of the week. So not surprisingly, my conclusions demonstrated that my experience was not unique. A lot of people used methadone maintenance for these same pragmatic reasons that had to do with, circumventing the illegalness of drugs. It reduced the harms of criminalization and policy rather than this sort of, I'm treating my addiction kind of thing. So, so the outcomes of my research, and I want to stress these aren't like I was the first person to think of these outcomes. People on methadone know this. Drug users know this. It's not like I made this amazing discovery because of my wonderful research. I see myself more as like a bridge, a communicator from like, hey, let me tell you all what we all know, in a way that, and because I have initials after my name, maybe you'll sort of take it seriously. But the outcomes were that it gave people a little bit of a different way of talking about methadone maintenance and how it benefits people. I wasn't saying, oh, methadone doesn't work. I'm saying methadone does work, but it works for different reasons than y'all think. And it, people started talking, and some people were referencing my research, talking about methadone maintenance as safe supply rather than sort of this behavioral modification kind of thing. Or methadone maintenance is giving agency to people who use drugs rather than a way to stop people from using drugs. Or methadone maintenance as a critique of the war on drugs, or methadone maintenance as a critique of addiction as disease narratives. And one of the most, gratifying things in my research has been that people, advocates and people on methadone maintenance have talked to me and been like, thank you for writing this in the research community. Again, I'm not saying that the advocates knew this, they talk about this, but they were like, thank you for getting this message into the research discourse. And thank you to see research that better reflects our experience. And that gives us a more liberatory perspective to challenge the structures that oppress us, rather than just, how can you fix us? So yeah, I wrote at the bottom, I guess I've already sort of made this pretty explicit, but my work is much more informed by my own lived experience and from those around me than from my scholarly training. I just want to point out, it is hard. It's hard for outsiders to break out of the conceptual frameworks without help from insiders. I'm a sociologist. I recognize that the norms, the sociocultural ways that we construct ideas, they exert a tremendous effect on how we conceptualize things. And it's really difficult for someone who hasn't been through the direct experience to break out of that idea, and it would be difficult for me if I was studying something I had no experience with. I mean, clearly, if I was studying the experience of being a stigmatized African-American, I would want a stigmatized African-American to help me with that. I wouldn't just be like, hey, I can handle it with the survey, because that's not gonna work. This is especially true for hidden, marginalized activities like drug use. People who use drugs have a vested interest in lying, a vested interest in hiding things, a vested interest in internalizing dominant normative narratives. I mean, in the methadone clinic, this came up all the time, especially before I was disclosing. People would say like, well, yeah, of course I'm trying to be in recovery and I'm doing my best for my counselor. And I'd be like, come on, man. But I get it that they have to tell their counselor that, or else they will suffer from that. If you don't reproduce the dominant narrative or internalize it, you could be in trouble. So as I mentioned, I didn't start getting the good data until I disclosed my status. And really the takeaways, I would not have been able to reach the conclusions that I reached without my own experience and listening to the experiences of the other people who use drugs around me. I would not have been able to collect the data that I collected without disclosing my own experience. And clearly, I think that research on substance use will benefit tremendously from greater insight and participation of people who use drugs. And I want to thank the other presenters and the conference organizers and all of you for watching. I hope you got something from my presentation. Cheers.
Thank you, David. That was fascinating. We're going to have one more speaker who is Dr. Anik Borquez. Annick is going to talk from the researcher perspective. Annick is a HIV and drug use epidemiologist at the Division of Infectious Diseases and Global Public Health at UCSD. Her research seeks to improve the health of marginalized populations through developing, applying, and integrating mathematical modeling, cost effectiveness, and qualitative methods to better understand, predict, and respond to the intersecting epidemics of drug use disorders, overdose, HIV, Hep C, and other associated health harms. Annick.
Thank you, Ahmed, and thank you everybody for speaking. I think mine is going to be much less exciting than the previous two, and I feel very self-conscious because I'm in the position right now of like the modeler who is doing, basically I'm part of this group of modelers who haven't been engaging enough with people with lived experiences, even though I'm very interested in doing that. And I've put a few notes together. I'm trying to channel
your audio is really distorted for some reason.
Is it better now? Sometimes it takes a little bit of time. No?
No.
It's odd. It feels like it's a microphone issue or something. It doesn't sound like an internet issue. It's just like there's a lot of static.
Okay, maybe if I stop sharing my screen.
Maybe it's worth a shot.
Try it.
Can you hear me better now?
No, so it's
No, but you're also still sharing your screen, or you're still showing video.
Oh. How about now? Can you hear me better?
Oh, it's still there.
Maybe try logging off and logging back on.
Or do you have a headphones you can use?
Oh, not with me right now.
So while we're waiting for Annick to come back on, are there any questions for our panelists? So maybe I'll start. Yeah. No, Ben, go ahead.
It's not a question. I guess it's a question, a bit of an observation. So this question has come up around access. From the researcher's perspective, access can be a challenge, but I want to sort of like really, even if, for example, I've worked extensively in syringe programs in the US and Latin America. I'm a HIV provider at Healthcare for the Homeless. I have plenty of, I'm comfortable interacting and talking to people who use drugs, and I have valuable and meaningful relationships with people who use drugs. So it's not, I feel comfortable interacting, but to me, it also feels like a different type of engagement. It's hard for me to understand, how do I engage my friends at the syringe service program in the modeling effort, right? I know it must be possible, but it does feel like there's a barrier there. And maybe it's honestly, as much as I want to say I'm comfortable, maybe some of it is stigma, right? I can't imagine they would be interested, and I'm sure actually they would be. But I do think, from the researcher perspective, even without the sort of otherization, right? Moving around the otherization of people who use drugs, if we just assume that we're on the same page there and actually feel comfortable, it still feels like there can be an access issue around research specifically. So how do we overcome that? Because I'm sure that issue is all on my side, but I'm not quite sure how to navigate it.
I mean, I think that I have two thoughts on that. One is to talk to someone about what modeling is, actually explain it and how it could benefit, because I think that's, you talk about modeling and people are like, what the hell is that? We know what qualitative interviews are, but you hear that and you're like, oh, okay. But also I think when I've talked to people who are doing modeling and they've described to me what they're doing, and when I've told them, you know, when I've given them like more detail for them to think about, I know it's been impactful. I know that it's been helpful to them because there's things that they haven't thought about. And I will say, like, it's good that you are connected. But I was just thinking actually when you were talking about this doctor that is involved in like some research in Toronto who, you know, when we learned how, I'm just gonna give this as an example because it's like really interesting. But when we learned about how to do overdose prevention, we learned from other people who use drugs. It's like a very natural thing in your life to want to give rescue breathing. It's like when you've seen someone overdosing, you're like, oh, I should give them oxygen. That's like really, really important. So before everything took off here, we trained each other in overdose prevention. Dan Big actually came here. Americans were sending us naloxone, which we then we were distributing. Well, thanks to Rafi Balian mostly, who unfortunately passed away. We were distributing it to people on the streets. We were training them. We had come up with our own training. We had developed all of our resources. And then a doctor came in who says he was connected to the community, who worked in the community, who then worked with other people at a higher level to say that rescue breathing isn't what we should be doing, it's chest compressions. And so that's how chest compressions came about in overdose prevention. And we were like, no, we know it's rescue breathing. And so we ended up in a battle for almost a decade around the overdose response education, because somebody who had more like levels of, they had like a particular credential around them was seen as knowing more than we did. And it has been one of the most frustrating and hurtful experiences I've been a part of, because now overdose education in the province of Ontario is fucked. It's like there's groups of us who are like rescue breathing, and then you've got, you know, the pharmacy saying rescue breathing, and then you have the public health unit saying chest compressions. Why are you doing chest compressions on somebody who is alive? And also, like, imagine you're all high on fentanyl and someone ODs and you're trying to maintain a chest compression. Like, putting your mouth on someone is so much easier and actually makes it makes so much sense. And I think these are the things we have to think about, is like, what is like that from a perspective of someone who is in community. What are people's motives? You know, like when someone's working in a site or they're actually connected, I like trust them more. You know, I'm like, oh, they're around, we see them, I trust them, they're on our side. That to me, they like serve people who use drugs. I trust them more. And then when someone who is like sort of on the outskirts, I've seen it happen over, and they'll find certain people to back up their research, and they say, well, I'm working with people who use drugs, and they've like seriously like screwed us over. You know, like I just remember the day that we got rescue breathing back into the guidelines, and in a room full of government officials, I sat and cried because I had to work through the police, the fire union, the paramedic union, and get them to bring forward the evidence around rescue breathing and prioritizing it, because this man was never going to let it go. It went into the news when it got changed and said that rescue breathing was the hardest thing he had to do in the emergency department. He never had to do rescue breathing in the emergency department because you have oxygen tanks. So, you know, just to show like, it can go, like, we really have to build these very trusting relationships where we believe that we're all on the same track. And yeah, just really appreciate that you were like working all of it, because there's people who are outside who we think are gonna be on our side, and they just literally turn out not to be. And I don't know how we hold them accountable. Maybe other researchers have to, other doctor colleagues. I don't know.
So thanks, Zoe. Annick, can you try again with your audio? Annick was here, I don't. Maybe we'll go to Bruce's question while we're waiting for Annick.
Yeah, I don't think she's on right now. I just wanted to pick up on something that Zoe said, which is, you know, not having a situation where a researcher picks one or two people who happen to, you know, have an opinion or make a statement, people with lived experience that supports their their narrative. And also, you know, there's so much diversity of experiences in which drugs are used by different people and how they use them. And so, you know, I mean, this is not, we're not alone in having this concern about, you know, reflecting a variety of experiences. So you suggested working with organizations, you know, that can help source people, you know, that will help answer the question. And you mentioned the Drug Users Union is one of them. Can you talk a little bit more about how that would work? Like if I went to meet with the Drug Users Union and describe the research that I was doing?
I mean, there's a users union, the Urban Survivors Union in the United States. I don't know where you're located, but there's lots of like drug user groups in different cities around North America, and contacting them and being like, this is the kind of research I'm interested in doing, and seeing if it's an interest of theirs and trying to have a discussion is like, I think it's really integral and important to the work. And the Urban Survivors Union has written about wanting to be more involved and want to be more involved in their own research. The Canadian Association of People Who Use Drugs, they hire their own researchers now to do their work like with them. So once people become involved and they trust them, they're now hiring researchers so that it's more community driven. And I think, you know, those groups are really, really important because they might have a more diverse membership. And you're right about people's experiences. You know, for me, like when I first got into drug user organizing, I was around lots of people on methadone and men, and you know, that wasn't like what my experience was, but it was cool that you'd be in this space. Like mine was around crystal meth and pills, and I smoked drugs. I didn't inject, and I mean, I still don't inject, but I use in other ways. And that's not, you know, and the priority often is around injecting because that's how our funding has been. That it's also been driven by HIV and Hep C. So we're not even getting to we don't even, you know, and we're sometimes really tied to like what the funding response is in terms of like the research we're going to do. And that might not be what the community is interested in. Like right now, the city of Toronto put out an alert like, oh, smoking is really popular. It's like smoking drugs has been popular forever. It's just because you didn't notice doesn't mean that it's popular now. We know people smoke fentanyl. They smoke oxys off oil too. Like they smoke crack here. It's still like the commonly used drug. So yeah, I think building those relationships and even getting an introduction from somebody you know to be like, hey, like I want to do better at this work. Like that's really important. It's super key. And I think people are open to it because they also want to be part of that research agenda. And they also like the resources that researchers come with, which is helpful. I think David Frank's a USU member, see, so there you go. David's a good connection. But they have they're people all over the country, so. Yeah.
I would also briefly point out that, you know, it goes without saying, the more engagement, the better, because I think researchers are going to have to accept on some level that they're going to trust people who use drugs more, people from their community, like any community trusts people from their community more. It's probably even worse though with drug users because of the relationships that we've had with researchers that have tended to be so exploitative, and we feel like we're just a resource to be mined. So I think there needs to be you need to tread softly. And I definitely do recommend sort of the more drug user rights unions like Urban Survivors Union, because there are some organizations that are, you know, that don't really represent what I would say is the feeling of the people. But I think there needs to be some acceptance that you're never gonna ever be accepted in the same exact way that someone who uses drugs will be.
So Annick is back. Annick, can you try your audio now?
Yeah, although I'm not sure it's, I think it's nice to just keep going with the conversation, right? Do you think, I mean, do we have much time?
We can extend your time a little bit, and you do sound better.
Okay, well, I'll share my screen and I'll be brief because I think whatever is being shared now is probably more valuable than what I'm about to say. but just to get the perspective from somebody who's been involved in both modeling and trying to do qualitative research to inform the models. I just tried to address the 3 questions that were given to us. And the first one for me was actually difficult because it was like, well, why to engage people with lived experience in drug use modeling research? And to me, it's such an obvious answer that if your research is in drug use, you want to, you want to understand it as much as possible. And the best way to understand it is by engaging with people who are from the community. And I mean, it's the research that you're interested in, so you want to get in there as much as possible. But I can see how it's not the case for everybody, especially because the modeling field is very heterogeneous, and many people come from physics or from other much more theoretical fields, and they might be much more into the actual like modeling experience than the engagement with the communities that they're working with. So I thought about it in a more practical way, like why do we want to do this in the scientific kind of like process? And the first one, I mean, Ahmed already spoke about it very clearly, but preventing harm. We want to make sure that the questions that we're asking are, are not potentially going to cause harm in the community. Also ensure relevance and usefulness of the research. So I don't know, like we might think that investigating methadone in Tijuana is the most pressing issue when actually it is not at all. And we're like, potentially wasting our resources and our efforts in investigating something that is not a priority for the community, and that at this stage they really need something else. So yes, better understanding the context in which the research is unraveling, and better identifying priority questions for research. Also improving the quality of the research, ensuring that the data collection instruments are appropriate, that they're sensitive and respectful, that they're clear, because we want to prevent possible misinterpretation if we are wanting to get data that is actually accurate when informing our models, and also building trust with the community to have truthful accounts of their experiences in order to model these in the right way, and to verify our assumptions. When we're thinking about modeling something, there's always a range of assumptions that come into a model, and the best way to actually know whether they make sense is by talking to people who have the experience, and also to encourage the dissemination and use of findings, because I think this is especially true for modeling, but it's rare that a modeling paper is being used in the harm reduction community and by people who use drugs. And I think if we learn to involve people who use drugs all along the process, from the design of the question to the implementation of the study to the dissemination of findings, it's much more likely to actually be useful and to actually be used. So that's kind of my take on why it is important to engage people with lived experience in research, in modeling research specifically. And in terms of how to engage them, we've been speaking about this. I'm answering this question from a very, I guess, naive, like from my own experience and how I've done it so far, from like the stance of modeling. And so I think volunteering and at and engage with community-based organizations that are working with people who use drugs on a regular basis, just helping. So without any intention to that necessarily informing your research, to me has been really useful. Like I volunteered a lot with the wound clinic in Tijuana that serves people who inject drugs, with wound care in the streets of Tijuana, mostly for people who are like in a situation of homelessness. But also for those who are lucky to be part of an ongoing study with people who use drugs. I think spending a lot of time in the study offices and engaging with the field staff, also describing the research goals to them and getting their views, and then observe and take part in data collection efforts. I think when you hang around the study, you end up in situations where like an interviewer is missing or a participant just arrived that hadn't been there for like 2 years, and there's no interviewer to apply the questionnaire, and you're there and you end up applying the questionnaire, and you understand much better how how the answers are being obtained, and how much you can trust the data, more in terms of like, oh, this question is actually really complicated, or it's very different when you have to apply it yourself, and when you engage in how it's being answered. And I'm speaking here about structured surveys. I've also applied polling booth surveys with questions that were specifically useful for the modeling, just to see whether there was bias in responses to sensitive questions. We were asking a lot of questions on sex and different forms of sex, and anal sex, and condom use during anal sex, and it was kind of a bit of an abnormal polling booth method, because normally it's very like there's not much engagement, but because I was the one doing it, I was chatting to participants, kind of explaining what we meant with each question a little bit more. And I did find that in terms of drug use, we were getting very similar responses, but in terms of sex, there was a lot of underreporting in the survey versus what I got in the polling booth, because there was a lot more reluctance to share about sexual life among participants, whereas they were clear that they were coming here as experts on drug use, and they were much more comfortable speaking about drug use than about sexual their sexual life, which to me makes a lot of sense. And then, yeah, like to me, the like entry to better understanding people who are engaging in drug use is to actually carry out qualitative research to inform or complement models. And I'm kind of going in kind of like increased level of engagement. So, I mean, ideally building a community advisory board and consult them throughout the study. But finally, and I've seen a lot of that being mentioned in the chat, and I think it was also part of the conversation, but actually implement the study, the modeling study within a community-based participatory research framework, where you're actually having people who use drugs as researchers in your project, and participating to the design of the research question, the design of the model, the parameterization of the model, and which questions we're asking with the model, and interpretation of findings and dissemination of findings. So that would be, in my opinion, the ideal way to do it. But I also acknowledge that there are many changes to it, challenges, sorry, to it. Firstly, starting with modeling being extremely time consuming. I mean, I might be slow as well, but it is very intense, and it takes a lot of time in terms of like getting all the parameters from the literature review, getting your model to work, fixing the bugs. It is a very time-consuming task, and I think that I mean, as Zoe was mentioning, and here, like, you know, I'm kind of in a way speaking from the side of the researchers, but we are under a lot of pressure to publish and to get funded to survive. Like, if you want to continue being a researcher, yeah, it is kind of very difficult to take that time. And I mean, I say it from like those first few years where I was like really trying to get funding, and I was volunteering a lot at the wound clinic, and you're making peanut butter sandwiches, and you're thinking of, oh, I should be writing this grant, and you kind of wonder whether you're putting the time where you should, and at the same time you're like, well, I want to give back something that is concrete to the community, that is, you know, in a way helping me with the research. But I think our research environment is not very well made to allow us to spend that time with communities. And also the funding and the publishing environment for modeling is not that supportive of mixed method research. So I mean, I tried to get a grant funded that was specifically looking at mixing modeling and qualitative research to make the modeling better in the context of injecting drug use, and I never managed to get that funding. I've written like a paper that merges qualitative and modeling, and I've had that paper rejected. So I think it's not, we're not really there with really engaging people who use drugs in the modeling field. We're behind, basically. And I'm hoping that that's something that we can change. And I think conversations like this will definitely help, I hope. And I think sometimes the problem is also that the scale of the study may feel incompatible with local engagement. So for example, right now I'm leading this study on predicting overdose death rates at county level in the entire United States. And so it's kind of difficult to say, oh, how am I gonna do the qualitative research representing the entire United States? Like, how do I do this so that it is still in line with what we're trying to do with the study? And I think then it's useful to, for example, work with a National Harm Reduction Coalition who work with many organizations at state level. So it might be a different way of engaging, but it's still engaging with people who have much more knowledge of what's happening on the ground than I would have. So I think that's kind of like challenges in terms of doing it or starting to do it in the first place. But it's also sometimes challenging once you're actually doing it. So there's often a contrast between the researcher's perspective and that of people with lived experience. For example, in terms of key issues to be addressed to improve health. And I mean, I'm trying to think of a very simple example, but we know, for example, that in Tijuana, the violence situation is incredibly difficult, and that I mean, you have a much higher chance of dying that day because you know, because of homicide than actually because of HIV or anything else. And so to me, that's something that is clearly one of the key issues to be addressed in that community. But when you actually chat to participants, it's so much part of their lives that if you ask, oh, what do you think are the main issues, you know, for people for people who use drugs, they wouldn't necessarily say that because they're very used to it and it's just normal. So in that sense, I think yeah.
Sorry, we're like almost into the next session time. And I do want to give people just a couple of minutes before the next session. So yeah, I'm really sorry, but I think we do need to wrap up.
No worries at all.
Okay, I want to just thank all of our speakers and apologies to everyone for running late, but I think we just had a really fantastic set of presentations. So I'll hand it back to Natasha.
Yeah, thanks so much. And sorry about that, Annick. Thank you so much for everyone's presentation. Let's take a few minutes break. The next session starts at 3:45. So we'll take about a 3 to 4 minute break and see you then. Thanks.